Hello and welcome to the JASE Podcast Winter Weekly Series. Editor-in-Chief Dr. Michael Picard, Managing Editor Deborah Meyer, presented by myself, Amar Jory. This is our final broadcast for 2020. Today we'll present an article from the December 2020 issue and a final message from Dr. Michael Picard to round out the year. Today's article is entitled Identification of Need for Ultrasound Enhancing Agent Study, or the In-Use Study, by Ariane Fraiche, Warren Manning, Sheriff Nagua, Michael Main, Lawrence Markson, and Jordan B. Strom. Ultrasound enhancing agents have become an indispensable clinical tool to improve echocardiographic image quality. Consisting of microbubbles with permeable shells containing a high molecular weight gas, enhancing agents are intravenously administered during echocardiographic imaging to improve LV blood pool and endocardial border delineation. 3 commercial enhancing agents are approved by the U.S. Food and Drug Administration for LV opacification and are recommended for use in patients with suboptimal imaging quality by the 2018 ASE guidelines. Several studies support the cost-effectiveness of ultrasound enhancing agents and their efficacy in technically challenging critical care and emergency department settings. Certainly, ultrasound enhancing agents are recommended on a case-by-case basis as determined by unenhanced image quality. This need for assessment of unenhanced images may lead to time delays in obtaining and administering enhancing agents due to insufficient numbers of available trained personnel to place peripheral IV access for enhancing agent administration or to obtain, prepare, and administer the agent. Indeed, one of the largest barriers to UEA use is the need for IV access, especially in outpatient clinical sites that may lack the resources or time to place an IV line. Therefore, an algorithm used before image acquisition to identify outpatients referred for TTE imaging who may benefit from UEA imaging may also allow streamlined clinical workflow, increase the rate of enhancement agent use, and decrease the frequency of suboptimal studies. Additionally, limited data exist on long-term trends in the use of ultrasound enhancing agents and suboptimal image quality. Therefore, we sought to 1. Describe temporal trends in inpatient and outpatient ultrasound enhancing agent use and suboptimal image quality on transthoracic echo imaging at a large tertiary care medical center, and 2. Develop and internally validate an algorithm to identify outpatients with high likelihood of ultrasound enhancing agent use or suboptimal image quality using only variables available before image acquisition. The methods and results section have been abbreviated for ease of listening in this audio recording. However, the full article appears in the most recent issue of the Journal of the American Society of Echo. Methods. Structured report data from 171,509 consecutive TTE studies in 97,515 patients who underwent transthoracic echo imaging from January 26, 2000 to September 20, 2018 were analyzed. Trends in ultrasound enhancing agent use and suboptimal image quality were examined. Among outpatients, that is 92,291 TTE examinations, which was 56,479 patients, the data set was randomly split into a 75% derivation sample and a 25% validation sample. Logistic regression was used to model the composite of either ultrasound enhancing agent receipt or suboptimal image quality. meaning 2 or more non-visualized segments, using only variables available at the start of the TTE examination. Model performance was tested in the validation sample. Results. A total of 4,444 transthoracic examinations in 3,827 patients, or 3.9%, involved ultrasound enhancing agents, and 28,468 TTE examinations, or 16.6%, in 21,994 patients, 22.5%, were suboptimal. Ultrasound enhancing agent use increased over the observation period. Among transthoracic echo studies with suboptimal image quality, ultrasound enhancing agent use was lower in women. Among outpatients referred for transthoracic echo imaging, older age, greater weight, and higher heart rate best predicted ultrasound enhancing agent use or suboptimal image quality. Model performance in the validation sample was excellent. Discussion. Despite compelling indications and guidelines for use, ultrasound enhancing agent use in transthoracic echo imaging remains low. In the present retrospective study, at a single large academic medical center, ultrasound enhancing agents were used in only 2.6% of examinations and 7.7% of suboptimal transthoracic echo studies. Among those with suboptimal image quality, ultrasound enhancing agent use was less common in women. Ultrasound enhancing agent use was more common in older individuals, inpatients, overweight individuals, and those with depressed LV systolic function. Weight and inpatient status were the most important predictors of the composite outcome of ultrasound enhancing agent use or suboptimal image quality. Among outpatients, a prediction model based on 3 parameters available before image acquisition, for example, age, weight, and heart rate, predicted the composite outcome with very good discrimination and near perfect calibration. If externally validated, this algorithm could be used to identify outpatients before transthoracic echo image acquisition who might benefit from ultrasound enhancing agents and thus may streamline workflow to allow IV placement before scanning to improve appropriate agent use. Use of ultrasound enhancing agents in stress echocardiography. Our study extends prior work to develop a clinical prediction algorithm for ultrasound enhancing agent use in stress echocardiography. Bernier et al. Used an 11-point clinical score using 8 variables: age, sex, BMI, more than 2 risk factors for coronary artery disease, use of dobutamine stress echo, abnormal ECG findings, history of smoking, and history of coronary artery disease, to accurately predict ultrasound enhancing agent use in individuals undergoing stress echo. The present prediction rule differs by predicting the composite of ultrasound enhancing agent receipt or suboptimal image quality, i.e. potential benefit from ultrasound enhancing agents in TTE imaging, not stress echo, using only 3 variables, all available to clinicians before image acquisition. We similarly identify age and weight as significant risk factors for the composite outcome for TTE. However, as no testing or clinical knowledge is required for the present algorithm, it could be easily implemented. Value of ultrasound enhancing agents in clinical management. Current evidence supports the use and cost effectiveness of ultrasound enhancing agents for LV opacification for studies of suboptimal image quality. In 2009, Kurt et al. Assessed the impact of ultrasound enhancing agents on image quality and clinical management in 632 patients with technically difficult TTE studies, prospectively enrolled at a single center. The impact on clinical management was related to improved endocardial visualization and was greatest for ICU patients, followed by non-ICU inpatients and outpatients. Accounting for downstream cost savings from avoidance of additional diagnostic procedures, a cost-benefit analysis suggested a $122 per patient cost savings when a ultrasound enhancing agent was used. A retrospective study by Dolan et al., 42,028 patients from 3 institutions, showed that ultrasound enhancing agent use was associated with improved diagnostic accuracy and no adverse effects. On the basis of available data, ultrasound enhancing agents are recommended to improve the accuracy and reproducibility of LV functional assessment and wall motion analysis, not satisfactorily as assessed on unenhanced TTE imaging. Trends in ultrasound enhancing agent use. Despite potential benefits, ultrasound enhancing agent utilization was low in the present study, with only 7.7% of those with suboptimal images receiving an agent, despite similar rates of growth in suboptimal image quality and agent use over time. However, after 2008, we observed a large inflection in the growth of ultrasound enhancing agent use, corresponding to relaxing of the FDA's black box safety warning for petriflin-containing ultrasound enhancing agents that year. In October 2007, an FDA black box warning was placed on ultrasound enhancing agents with contraindications for severe cardiopulmonary disease and mandating a 30-minute post-injection monitoring period. Subsequently, compelling safety data have emerged to support ultrasound enhancing agent use. In 2008, the FDA downgraded contraindications for individuals with severe cardiopulmonary disease to warnings and removed the 30-minute monitoring period from labeling, reflecting emerging safety data. Coincidentally, we observed a nearly threefold increase in ultrasound enhancing agent use in 2008. However, despite the existence of extensive data supporting the safety and efficacy of ultrasound enhancing agents in the current era, that is from 2014 to 2018, ultrasound enhancing agent use remained at only 14.1% in those with suboptimal TTE image quality. Reasons for the growth in suboptimal transthoracic echo image quality are uncertain but may relate to increasing obesity among individuals undergoing imaging, as the mean weight of individuals increased by 4.7 kilograms, or approximately 10 pounds, over the 18-year period, as well as changes in the perception of suboptimal image quality among transthoracic echo readers. Of note, although men had suboptimal image quality at a higher rate than women, among those with suboptimal image quality, ultrasound enhancing agent was less frequently used in women. Additionally, although women had greater increases in preconditions for agent use, example BMI, over time, no sex differences were observed in temporal changes in suboptimal image quality or uptake of ultrasound enhancing agents. In total, these results support observations that suggest women may receive less optimal cardiovascular care, and reasons for this disparity should be explored in future research. Barriers to ultrasound enhancing agent adoption. Robust data currently exist to support the efficacy, safety, and cost-effectiveness of ultrasound enhancing agents in practice. Historical perceived barriers to use include costs, staffing, IV access, and the additional time needed for study planning, preparation, and acquisition. Subsequent research has found ultrasound enhancing agents to be cost-effective by reducing downstream use and associated with a reduction in acquisition time when implemented properly through reduction of sonographer struggle time. Current barriers to their use includes insufficient awareness of the utility and benefits of ultrasound enhancing agents, lack of training in administration of agents, absence of a formal training pathway for development of skills in IV placement, and mechanisms to identify a priori which patients might require IV placement for ultrasound enhancing agent administration. Reasons for low ultrasound enhancing agent use at our institution may include historical requirements for verbal approval for use from the attending transthoracic echo reader or cardiology fellow, a policy no longer in place. Other requirements include storing of ultrasound enhancing agents in the echo lab versus sites of most common use, lack of use of ultrasound enhancing agents for off-hour emergent studies by fellows or on weekends, and insufficient training of nurses and other health professions for administration of ultrasound enhancing agents. An additional barrier to the use of ultrasound enhancing agents is the insufficient number of trained personnel to place IV lines. The ASC supports training sonographers in IV placement and ultrasound enhancing agent administration. However, for many hospital-based echo labs, this requires hospital approval and educational support to train personnel in venous anatomy, technique, and the risks and benefits of the procedure. Multiple sites, including the present one, have demonstrated that ultrasound enhancing agent use is higher in ICUs and on inpatient floors. Although this may be due in part to the greater prevalence of suboptimal image quality in these settings, it may also reflect the larger proportion of inpatients with pre-existing IV lines, thus removing a major barrier to agent use. In the present study, agent use was more common in inpatients, even when transthoracic echo imaging was performed in the echo lab. Given that rates of suboptimal image quality and potential efficacy of agents are greater among inpatients, it is reasonable to consider ultrasound enhancing agent use for all inpatients and to plan workflow accordingly to ensure appropriate access to the agent for inpatient studies. Additionally, further research is necessary to understand factors related to the underuse of ultrasound enhancing agents in circumstances in which IV lines are already in place, such as in patients. In outpatient settings, use of the present prediction rule to identify a priori patients likely needing agents could help improve uptake of agents by streamlining workflow and preemptive IV placement in appropriate individuals. The present prediction rule could be implemented using a wide web-based or smartphone app-based calculator or integrated into the electronic ordering system to determine an individual's likelihood of potentially benefiting from an ultrasound enhancing agent. Thus, individuals with high probability of benefiting from ultrasound enhancing agents could have IV lines placed before scanning to improve workflow. Importantly, this algorithm is not meant to be prescriptive or to indicate necessity of ultrasound enhancing agent use. For example, not all patients with sinus tachycardia benefit from ultrasound enhancing agents. Rather, it is intended to be used to identify individuals with sufficiently high post-LV test probability of either ultrasound enhancing agent receipt or suboptimal image quality that IV placement is reasonable to consider a priori to improve workflow. In the example used, a heart rate was higher in those receiving ultrasound enhancing agents and with suboptimal image quality. Heart rate may serve as a proxy for other unmeasured factors that influence image quality and ultrasound enhancing agent use. Limitations. Although large and spanning nearly 2 decades, the present study had several limitations. First, as a retrospective analysis, causal inference cannot be inferred using the present methods. Second, the model prediction accuracy may differ when applied to a dissimilar population that uses ultrasound enhancing agents more frequently or has different rates of suboptimal image quality. External validation at a center with greater ultrasound enhancing agent use is planned. Additionally, temporal trends in ultrasound enhancing agent use and suboptimal image quality observed locally may not generalize to other clinical settings or regions. Third, the presence of a suboptimal study does not imply that ultrasound enhancing agent administration would have improved the study's diagnostic yield, though it suggests potential benefit. Fourth, as individuals with extremes of age, weight, and height and heart rate were excluded, the present results may not generalize to these populations. Fifth, it is possible that a different machine learning technique, for example, artificial neural networks or support vector machines, may improve model performance. Sixth, as detailed information on the timing and presence of IV placement was not available, the conclusion that IV placement represented a major barrier to use is inferred. Finally, among studies in which ultrasound enhancing agents were not given, it was not possible to discern the sonographer's assessment of image quality, and thus agreement between physicians and sonographers on the decision to give ultrasound enhancing agents cannot be assessed. Conclusion. In this large single-center retrospective study of transthoracic echo imaging, ultrasound enhancing agent use was infrequent and less common in women with suboptimal image quality. Among outpatients referred for transthoracic echo imaging, an algorithm with 3 routinely collected variables available before echo image acquisition, age, weight, and heart rate, accurately predicted the composite of ultrasound enhancing agent receipt or suboptimal image quality. Predicting which outpatients referred for transthoracic echo imaging may benefit from an agent's use before image acquisition could be used to select patients for IV placement before imaging, thus improving workflow efficiency and diagnostic study yield. Further research is necessary to understand reasons for the underuse of ultrasound enhancing agents in circumstances in which IV lines are already in place. I would like to reiterate the highlights from this study. 1. Ultrasound enhancing agents can improve suboptimal image quality on transthoracic echo. Although safe and effective, ultrasound enhancing agents use is limited by anticipation of need. 3. 3 variables accurately predicted potential benefit from ultrasound enhancing agent in outpatients. These variables were older age, greater weight, and higher heart rate. Finally, this algorithm may help identify outpatients who benefit from IV placement for ultrasound enhancing agents a priori. That concludes the audio long read of this article, which is present in the current issue of the Journal of the American Society of Echocardiography, December 2020. As this is the final episode of the podcast for 2020, I wanted to round out the year by reading Dr. Michael Picard's editor's comment from the June issue. Although this is not part of the December issue, it really captures the spirit and focus of 2020. The title of Dr. Picard's comment is "Life is Dynamic, and so is JASE." Dr. Picard writes, "I had planned that this June issue of the Journal of the American Society of Echo would focus on the role of echo in surgical decision-making and also include some cutting-edge reports that would serve as a complement to the ASE's annual scientific sessions. However, the world changed quickly, so I felt it was important for the journal to do so also. Thus, although this issue includes some of our typical content, a major focus of it is now on echo and COVID-19, caused by the severe acute respiratory syndrome coronavirus 2. In this issue, I have included a series of statements from the ASE related to various aspects of the disease, some perspectives regarding the pandemic by authors from various hotspots around the world, and some rapidly compiled data regarding how echo utilization has evolved during this crisis. A challenge in communicating such dynamic information in a journal published only once a month is, of course, that by the time the reports are read in June, some of this information, composed in March, will be out of date. One solution has been that we post all reports online as soon as they are prepared for publication. However, this still takes several weeks from time a report is accepted to its appearance on the website. For the reports on COVID-19, I felt that even this was not adequate, so we modified our standard process. The COVID-19 related reports published in this issue were posted immediately on the JASE website in early April in the form submitted by the authors before they were edited for publication. This provided all readers near instantaneous access. The price we pay for this is that there may be some minor grammatical or formatting errors on those postings, but these were corrected in our final published versions. On the JASE website, we also have a section that provides links to other important COVID-19 related resources. These links also allow access to the most recent version of ASE statements, as these are living documents that undergo modifications when necessary. Two of the reports presented in this special focus section provide anecdotes and personal opinions about various aspects of diagnosis and treatment during the pandemic. Although our JASE editorial team prefers to publish objective, evidence-based information, we thought it important to communicate these perspectives from caregivers on the front lines, as they highlight issues and approaches we all may benefit from. The discussion regarding allocation of limited resources is a grim topic, and one I hope that few of us have to confront, but it is best to be prepared and think about this in advance. I also fear that this will not be the only pandemic many of us treat in the coming years, so experiences now will continue to benefit us in the future. Compiling these rapid communication reports in a very short time would not have been possible with the efforts of many people. I want to particularly recognize the reviewers who provided extremely rapid turnaround and yet comprehensive and helpful reviews. They, of course, must remain anonymous. Also, the authors deserve recognition for working very promptly to revise their reports. And special thanks to the staff who got the information onto our online platform so quickly. Our JASE Managing Editor, Debbie Meyer, ASC Chief Standards Officer, Rhonda Price, our Elsevier Journal Manager, Colin Conway, and our Elsevier Publisher, Jane Krakowski. I have been impressed by the commitment, creativity, comradeship, and resilience of the echocardiographic community. If it has not already occurred, by the time you read this, it is likely many of us will be asked to take on additional or different responsibilities than our normal ones. All of these efforts are appreciated by the world, and I hope we may celebrate your accomplishments soon. Thank you. That concludes the JASE Podcast Audio Long Reads Winter Series. I need your feedback for this podcast. For example, what more would you like to hear? Should we continue the weekly format? Please tweet your feedback to my Twitter handle @Amerjohri. That's AMERJOHRI. 2020 has been a challenging year for all of us. We hope that both the ASE and JASE were able to provide some sense of intellectual, ongoing community. We look forward to a fresh new start in 2021, and we wish you all happy holidays. Thank you.